the ERS, Wytske Fokkens, and she's going to tell us about the real paradigm shift that's going on, because we've heard about something happening in surgical techniques, but listen, what's happening in the medical treatment is something else. Please, Wytske.
Thanks, Per. Thank you very much. It's a real pleasure to be here, and I'm sure this new paradigm will change all our discussions about that we had earlier today. So it's a nice end of this talk. These are my disclosures. So this is more or less what we do. We see a patient, we do appropriate medical treatment, and Manuel already pointed out that appropriate is not always so easy to define. Then we do surgery plus appropriate medical treatment, and I heard already quite some variation of what that might be. And then we have sort of three groups: the controlled patients, we keep on medical treatment; the partial controlled ones that we step up, especially the polyp ones, of course, we give them steroids, systemic steroids in between. The non-steroids one, maybe an antibiotic or extra rinsing with xylitol, or, well, you can all find that in EPOS. And if it's really bad, we do revision surgery. And then we hope to get as many of our patients in the green part, but most of us who see all these terrible recalcitrant patients in real life have most of the patients on the red side of this graph. So this was for years the way we worked, and we all felt really good because the patients come to us desperate, have been operated 4 times, we do the 5th surgery, we do more aggressive medical treatment, and they also say, "Doctor, well, I'm definitely much better than 2 years ago." That's our daily practice, isn't it? But since 2 years, that really has changed, at least in my practice, because now we have biologicals. And that's what I want to show you in the coming minutes, how that's changed our daily practice. This is the care pathway that you can find in EPOS, telling you all the things we told you also today: what is appropriate treatment, how to define your treatment based on the endotyping. So I really think that is something new to look up or to listen to on Wednesday. It's not the part of this talk. But important is that we emphasize more and more, and it was done by Richard and Manuel also, that probably we shouldn't treat all our patients the same way, and that trying to endotype our patients, and that can be done quite easily with some questions, maybe a smell test, and some blood evaluation for eosinophils and IgE, can help us to define what the endotype of the patient is. And it's important to realize that type 2 inflammation can be allergic or non-allergic. It has nothing to do with allergy. So don't think I do a skin prick test. An allergic patient usually has type 2 inflammation, not always, but many non-allergic patients have type 2 inflammation. Most of my polyp patients have type 2 inflammation. Whether they are allergic or not doesn't make a difference. So that's something important to realize. And then you see here in a very easy graph the different cytokines that play a role in the type 2 inflammation, all leading eventually to eosinophilia, but also mast cells and basophils coming into that inflammatory response. And we know by now that there are a number of these cytokines that can be influenced by treatment. And we must say that Klaus Bachert was the one in Europe that led most of these studies and really pushed the field forward in this way. At the moment in Europe, we have now 3 registered biologicals for treating nasal polyps. That is anti-IL-5, mepolizumab, anti-IL-4 receptor alpha that blocks 4 and 13, dupilumab, and anti-IgE. And I want to show you in the coming minutes some of the data of the studies that have been performed with these biologicals. And I would like to start showing the data that really matter to a patient. All these studies actually start with a primary endpoint that is polyps. But I've never had a patient that came in and said, oh, I have so much trouble with my grade 2 polyps. No, never. So it's really intriguing that regulatory bodies like the FDA and the EMEA all want to see polyp results instead of what our patients feel about it. But I show you what the patients said. And this is the study with dupilumab, the hallmark study published in The Lancet 2 years ago, where the SNOT-22 score was measured, and you can see 2 cartoons here. I don't know, do you see what I measure? No. So you see 2 cartoons. The top one is a study for 24 weeks, so half a year, and the bottom one is a study for 1 year. The top one was just 1 dose compared to placebo, and in the bottom cartoon, after half a year, the dose was halved. So patients got an injection every 2 weeks, and after half a year, they get an injection once a month. And that becomes important in the rest of the talk. And you see that whether you, if you look just at the top cartoon, in at the first measurement moment, which was 8 weeks later, patient had enormous decrease in their symptoms, really massive, going from a SNOT of average 50 something to a SNOT of 30, eventually going to a SNOT of 20, under 20, which is what everybody in this hall that doesn't have chronic rhinosinusitis would fill in too. So we almost normalize our patients in a few weeks. And the other interesting part of this graph is the bottom cartoon, where you can see that if you halve the dose, after half a year, nothing happens. Exactly the same graph. Is that only dupilumab? No. With omalizumab, they did a very comparable study showing very comparable results on the SNOT-22. And the study with mepolizumab was a totally different setup, so very difficult to compare to the other two, but also showed a large and significant reduction in SNOT-22. Here in the MEPO study, patients were allowed to use systemic corticosteroids. So that is why you see that the placebo also goes down quite significantly, because a lot of those patients actually got systemic steroids during the trial. Well, let's look at some objective marks, like the nasal polyp score, and all the graphs, as you can see, look exactly the same. Also, the polyps go away. In many patients, in the DUPI study, after half a year, half the patient had at least a reduction of 2 points in their polyp score. The same for omalizumab. You see exactly the same sort of graphs. Also for mepolizumab, but it seems also to be a little bit less than the other two, but also reduction in polyps. And the most fantastic part of biologicals is the effect on smell. Patients who haven't smelled for 15 years, despite all our great surgery and fantastic maximal medical treatment, still couldn't smell or can smell 2 weeks after you give them a big shot of systemic steroids, come back after a week after their first injection and tell you they can smell again. And you see those data also here in the graph. Impressive improvement in their upset score. And again, for DUPI, the result remains the same if you reduce the dose. Same sort of data for omalizumab, a little bit less impressive for MAPO. And then, of course, the next question we have to ask ourselves, well, we start to work on the immunological system. Is that safe? Well, that's, of course, a question that's very difficult to answer in a relatively short period of time. We know omalizumab is safe because that is already used for treating asthma for 20 years. So that's pretty sure that it's a safe medication. But the dupilumab is on the market only for 4 years now, I think, for atopic dermatitis and asthma. So still quite new. And of course, although the early results of the first few years seem to be totally safe, we can't say for sure that that's the case. Now we have two big questions to answer, and that is, which patients are we going to give a biological? Is every recalcitrant CRS patient with type 2 disease a good candidate? For those of you who do not read the newspapers on this sort of issues every day, all these medication is not exactly for free. In Europe, the full dose of a biological is around 13,000 to 15,000 euro per year. So we have to convince the payers that that is worth the money. And in the US, it's, I think, even three times more, 2 to 3 times more. So it's really expensive. For now, that is a real issue. But I see a lot of young people in the hall. For you, it will not be an issue, because in 10 years, all these medication will be significantly cheaper and much easier to use. But for now, it really is an issue. So we have to be careful who we're going to give. Which recalcitrant patients really will benefit from this treatment? And then, of course, the second question is, which of these biologicals am I going to give to the patient? Well, let's look at the first question first. And we tried within Euphoria and within EPOS to, in a consensus meeting, to define which patients would benefit most from this treatment. And we came up with this graph. We said, well, if we say the majority of the patients do well after sinus surgery with appropriate medical treatment, that's not the group we want. So first surgery. And that will probably change over time, but for this moment, let's start to cut off that 50 or 60% that do well. So you need to have had surgery unless you're not, if you have a very, very severe asthma and you cannot be operated, or there is another very, very special reason why that's not an option, then we accept that. But 99% of the patients will have had surgery before. And then we try to help by defining a number of criteria that the patient has to fulfill to try to find the patient that has most benefit of the treatment. And that is evidence of type 2 inflammation, pretty obvious, because that's where the medication works for. And we define that as either tissue eosinophilia or blood eosinophils above 250 or 0.25, depending on the system you use, or a total IgE over 100. We said patient need systemic steroids or have a contraindication to systemic steroids. I have a lot of patients, especially the female part, that had so much systemic steroids in their life that now they have osteoporosis and they can't have it anymore. So, and we define that as more than 2 courses per year or a long-term taper treatment. Significant impairment of quality of life. If you're not bothered by your disease, and we all have those polyp patients, the polyps almost grow out of their nose and they say, oh doctor, I'm quite well, it's not so bad today. But some really suffer, so we said it's not 22 of over 40. Patient has to be have a significant loss of smell, and we define that as anosmic on a smell test. And finally, a diagnosis of comorbid asthma that was defined as asthma needing regular inhaled corticosteroids. 3 of those criteria brings you a group that will really benefit of the treatment, and I'll show you that in the next slide. These are the results of, we started this treatment in December 2019 when it came on the market in Europe, and we now treated about 200 patients, but this is about 131 of them. And I want to thank Rick van der Lans, who does this, who follows this cohort. And you see what happens to the patient. On the left is the nasal polyp score. Notice that after 12 weeks, the group is still 130 of the 131. We lost one patient because he had a side effect that we couldn't show not to be related to dupilumab treatment. And then the groups become smaller, of course, because it's a cohort over time. So the data of a year are only 26 patients. So you can't sort of compare over time, but you can see that patients have a quite fast and massive reduction in their polyp score, an enormous improvement in their snot score, and a significant improvement of their smell. And I would like to show you that in just one patient, an example patient, we use the Galenus app to ask all our patients how they're doing, and they fill that in every day. And I want to show you this graph to show how fast it goes. This is a day graph. So patient started January the 5th with the first shot of dupilumab. And you can see the different symptoms: facial pain, impaired smell, nasal blockage, runny nose, postnasal drip, and bloody secretions. And you see that all the symptoms, apart from the postnasal drip, are almost gone, say, a week or two later. So not all patients react so fast. Quite a lot do, about half do. We see them back after a month, and then they say, I'm absolutely fine, I'm great. But some, it takes a little bit more time, and it can be 3, 4, 5, 6 months before their optimal result has been reached. So that is what patients to give the treatment to, and then this is very, very recent paper from last week in Journal of Allergy and Clinical Immunology. That is the first systematic review and meta-analysis to compare biologicals. And you see here all the studies that were available at that moment on Dupi, omalizumab, mepolizumab, and benralizumab, and on aspirin desensitization at the end. And you see here that in this first comparison, and we still have to be very careful with these data because there are not that many studies to compare, but it seems that dupilumab is the most effective treatment. You see the most green parts, and omalizumab a little bit less, and mepo a little bit less again. But so for the moment, I would choose dupilumab, but that is really very, very early, and it might really change over time. So to summarize, in EPOS you can find this treatment scheme. Think about endotyping your patients, especially your recalcitrant patients in non-type 2 and a type 2 group. If you have the options to give a biological in your country, use this. If you do not have the option in your country, start to talk to your health ministry or your health payers that this really is something that is important for our patients, that will change the way we do our practice, and convince them that it's worth it. And that is something we have to do in the coming years, to convince that the money is worth it, and studies are ongoing to prove that. Finally, a small advertisement for EPOS. I don't know whether it's still needed, but you can download it for free. And you can also get a paper example if you go to the ERS booth in the exhibition area. And finally, I would like to invite everybody to come to the General Assembly on Wednesday lunchtime to discuss how we're doing in the European Rhinologic Society and to discuss our future. Thank you very much.
So thank you, Wytske. While Richard and Manuel gave us a lot of question marks, you've given us an exclamation mark. You know, it might be a little bit too good to be true, maybe? And the question is there any safety issue that you see these patients will probably have to be on lifelong treatment, maybe? Surgery is a one-time, in a lot of patients, one-time thing.
Well, of course, whether we know it's too good to be true is, I couldn't believe it, I must say. The first, the first period, now it gets a little boring because, I have a whole clinic with patients saying, "Hi doc, I'm doing fine," which is really, I really thought I was a good surgeon and I was the art person that knew how to play with steroids in different doses to get my patients better than anybody else. And well, this definitely humbled my ideas about myself considerably. There is one safety issue, especially for dupilumab, and that is that it blocks eosinophils going into the tissues, and sometimes that results in quite a lot of eosinophils in the blood, because they can't go anywhere, and the bone marrow is still producing lots of eosinophils. So in the first, say, between 3 and 6 months, you have to be careful about hypereosinophilia. That can give a severe vasculitis. And we have of those 200 patients, a handful, where we really struggle with hypereosinophilia. So that is definitely something to take into consideration.
David, you had a question?
I do. Thank you very much for that talk. Yeah, I would also echo that. I've been really impressed. We've got dupilumab now for about a year in Canada, and while it's really difficult to get access to it, once it's there, it's amazing, especially in those really difficult AERD patients where the polyps are basically growing back at you at 6 weeks, and no matter what you throw at them, nothing else seems to work. Yeah. My question for you actually specifically regarding the use of biologics in recalcitrant patients is, when do you start it? Do you do surgery and then you start it, or do you just start the biologic and not bother with the revision surgery?
Well, EPOS advised to do surgery first, and the reason is not that we think that a biological wouldn't be able to get rid of the polyps without surgery, but because we know that a considerable part of the patients do well with surgery, do well for a long time with surgery, and we feel, many Europeans live in healthcare systems that's like the Canadian. We have to explain to our healthcare payers whether it's worthwhile to do something. So we really felt that it was needed to be humble in what we asked. So I did a lot of calculations on how many patients would need, how many patients do you have per million that actually would need this treatment? And that is not that many. So many of our patients will be totally fine with what you showed, what EPO shows, and it is a limited group, but that is of course the limited group that we all struggle with so much, and for those patients this is a fantastic new possibility.
And on that note, I think we end this session. We want to thank all of the presenters and the audience for a great session with a lot of questions and one big exclamation mark. Thank you very much.